So I have been a chiropractor. I graduated from Logan University in August of 2016 when I was 8 months pregnant with Lorelai. And so I didn't open my practice until almost a year after I graduated. And I've been practicing since 2017 on my own. I joined the team at Jamaa Birth Village in October of 2018. So I've been there 2 years now. And when I joined, the team at Jamaa, I went to a fundraiser. They were fundraising for the new building that we moved into this year. And I went up to True, who is the founder of Jamaa Birth Village and also the midwife there. And I said to her, hey, do you have a chiropractor? And I would really love to be the chiropractor here. And she said they didn't have one on site. They had somebody they referred to, but that chiropractor was out in St. Charles. And I had asked if I could join the team at Jamaa, and True said they would love that. And so I started working there in October of 2018. And when to be completely honest, I was just super excited to be able to work at a birth center and to be able to work with so many pregnant moms, because that's where my love is. And that's where, where I specialize. And so I very naively walked into this, this world thinking like, I just really want to work with these moms. And what I learned very quickly was that a white woman in a very Black space it was difficult to earn the trust of the women that I was working with. They inherently distrusted me. And it continues to take time for me to gain their trust. And it helps that True trusts me and that she recommends me to care for her clients, and they trust her. And so because she says, please, you should see Nikki, she's really great, then that helps to sort of pave the way. But what I learned was that I really didn't know anything about the Black experience with doctors in America. So I've learned a lot, or I thought I had learned a lot in the 2 years that I've been working there. But when I started researching for this talk, I realized that actually I knew next to nothing about what the Black experience in America has been like as it relates to medicine. And so I'm going to try to share with you a little bit about what I've learned. I titled this talk Implicit Bias in Medicine. And then I reached out to a friend of mine who is a psychiatrist at Yale right now, and she's in her residency, and she is a woman of color, a St. Louis native. And I reached out to her because I know she's quite an activist, and I said, hey, I'm doing this talk, like, what are some things I need to think about? And her first response was, well, first of all, I hate the term implicit bias. I think we should just call racism racism, so maybe don't call it that. And I was like, okay, well, so we're gonna talk about racism in healthcare. I'm gonna give you a little bit of the history of how we got to where we are today and what it is that my patients experience on a daily basis. Keep in mind that where I'm coming from is the healthcare, is the childbirth world. So most of my experience comes with women and their OBGYNs and their experiences through pregnancy and delivery. But I think that a lot of what the women that I work with experience is universal in healthcare for Black people in America and people of color. Most of what I work with are African Americans, but in general, just anyone who isn't white or white passing. So I'll start with a little bit of history. So we all know that America was founded and slavery came with the founding of America. So when healthcare, one of the main goals of doctors very early on in American history and American medicine, one of the main goals was actually to prove beyond a shadow of a doubt that white people and Black people were completely different races. As we tend to compare ourselves to primates, they were trying to prove that just as apes and orangutans and gorillas are different species of primates, that white people and Black people were in fact different species of humans. And so a lot of medical research and a lot of medicine early in American history was in trying to prove that Black people were in fact a completely different species from white people. So what would happen, doctors, and training for doctors back then was like a couple of months at a school, and they didn't really know a whole lot, obviously. So, but once someone was a doctor, often they would purchase slaves to keep at their homes to experiment on. So it was great. And not only would they own slaves themselves that they experimented on, but slave owners didn't want to pay for healthcare for their slaves unless the slave was so sick that they couldn't work, right? Because the point of having a slave was so that they could work in the fields and work in your house and work and work and work. And so if they weren't physically capable of working anymore, if they were so sick from the fact that slave quarters were infested with bugs and all kinds of germs and sicknesses that just ran rampant through like all of the slave quarters all at once, and they were malnourished. And so if they somehow fell sick, gosh, we don't know how, they would call in a doctor to try to cure them. A lot of times, if a slave was so sick that they were never going to be able to go back to work, slave owners looked at it as helpful to then just gift their slaves to the local doctor to be used as for experimentation. So some of our most popular surgeries, especially surgeries on women, were actually perfected on slave women during this time. I gotta look for a name here. Dr. Sims, who is considered the father of modern gynecology, who perfected the fistula repair surgery in 1845, owned about 7, I think, slaves that he performed surgeries on over and over and over again. The same surgery until he perfected it and repaired a fistula is kind of disgusting, but it's when a woman gives birth, sometimes there's tearing, and it's when the tear is so bad that there's no longer a separation between the vaginal canal and the rectum, and so the woman is completely incontinent. It was in fact an incredibly common ailment in both slave women after they gave birth and in white women, and it would often mean that white women could no longer leave their homes, and they were sort of stuck inside, separate from society forever after they had children. And so because of this, it was very lucrative for Dr. Sims to figure out a way to repair fistulas so that white women could go back to their lives. So he used his slaves and did repeated surgeries on them until he could perfect this surgery. And he did eventually get to a point where he could repair a fistula and a woman could go back to her life. But when he was doing these surgeries on his slaves, he was not using pain medicine. One of the deep-seated beliefs that began during the slave days and lasts up till today is that Black bodies don't feel pain like white bodies do. And that is something that I hear repeatedly from my patients when they tell me stories about what they've encountered with their doctors. Black bodies don't feel pain the same way white bodies do. And which is not at all true, let me be clear, but there are still a lot of doctors who might not consciously believe that, but who operate that way. So Sims and the fistula repair surgery is one of the main surgeries that medicine perfected on slaves. The other one is Dr. Francois Prevost, who perfected C-sections in the 1830s, also on slave women, also without pain medication. They did not use even ether to put them to sleep. They just cut into them and hoped they wouldn't die. And so by the time he had perfected C-sections, then of course, when they started doing these surgeries on white women, they used pain medication and they used ether and they would put them to sleep. So much of modern medicine has been built on, just as the rest of America has been built on the backs of slaves who endured much pain in order to provide surgeries for white people who didn't have to feel pain. So I did most of my research from this book, which I would recommend everyone reading. It's called Medical Apartheid by Harriet Washington. Harriet Washington's a really interesting woman in that she's an ethicist and a journalist and has done a lot of medical research. She doesn't perform the research herself. She actually like gathers research and then like researches the research, if that makes sense. But she wrote this brilliant book on the entire history of American medicine and how we have misused Black bodies, and it's really enlightening. So if anyone would like to read that, I would highly, highly recommend it. It's disgusting, and I still haven't finished it because I kept having to put it down so I could take deep breaths and not be angry. But it's well worth the read if anyone is interested in this sort of thing. Or even if you're not and you're just interested in equality for all, it's a book worth reading. So that's most of the history. Started with enslavement when slaves were freed and they could no longer get bodies for free, I guess. Doctors moved on to still sharecropping in the South was still a thing, and sharecroppers were basically still slaves. I mean, like technically they were getting paid, but then they were also charged rent and you know, for food and things like that. So they never actually made any money, so they never made it off the plantation. So nothing really changed in medicine when slavery ended. Doctors could still get their hands on sharecroppers who owed their landowners money, and they could work off their debt by participating in experiments. But then there was kind of a shift when sharecropping was no longer a thing. And then what we moved into is sort of modern day, the prison system. So I don't know how much you know, and I didn't know this, but often pharmaceutical companies, when they need to do experiments on drugs that they're developing, there are 3 phases of drugs and of how a drug becomes available to the public. And the first phase is sort of like, let's see if we think this might work. Let's see if it kills anybody. And who's going to volunteer for those kinds of experiments, right? So they go to places where people don't really have much choice. For a while, they built teaching hospitals in urban poor areas, which were mostly made up of Black people, sometimes other immigrants, and sometimes poor white people, but they were overwhelmingly Black. And they would build teaching hospitals, and then they would offer free healthcare to people who needed it in the area, because the doctors needed to learn and they needed bodies. And so they would offer free healthcare, but really a lot of times on those particular patients, the poor people and the colored people, that they wouldn't really actually be trying to cure them at all. A lot of times they were using them for experimentation to see how much they could learn from them. Again, most of the time with the goal of finding a reason why Black people were not as good as white people. So after the teaching hospitals, and then Black people got rights, and then they couldn't extort them so much anymore. So then they moved on to using the prison system. So these days, and it's become less common because people have started throwing fits about it, but even up until the 70s and 80s, they were testing pharmaceuticals on inmates, and they would, they were phase 1. So it was basically like they'd pay the inmates like $10, $15, $20 for every experiment they participated in. And they would like burn their skin, and they would give them these medicines that like ate their insides, and they like did some really terrible damage to a lot of people under the guise of medicine, under the guise of trying to to come up with a new drug because they needed bodies. So I have lots of examples I could give you of different ways that that American medicine, and in conjunction with the American government, a lot of the times has abused Black bodies. But I want to give you, so there are some important patterns that Harriet Washington talks about in her book that persist today, patterns of how we use Black bodies, and what that means for why healthcare, how the healthcare system looks today, why Black people are reticent to trust their doctors, why they don't even want to go to the doctor unless it's like feels life-threatening. So here are the important patterns that she listed, and I'll give you an example that goes with each of them. So one of the biggest ones is the myth of medical distinctiveness, meaning that belief that Black people have to be different than white people. And so there are things about Black people that aren't true for white people, and vice versa. So like the belief that Black bodies don't feel pain like white bodies, we still see this today. So an example I can give you, I had a patient in my office recently who is pregnant with her second child, and I always ask, so tell me about your first pregnancy, tell me about your first birth. It's things that I need to know. So one of the stories, so the story she shared with me about her first birth, she was, went to the hospital, got an epidural. Her labor wasn't progressing. When they placed the epidural, she told them, I can still move my legs. And I don't know if you know anything about epidurals, but one of the things that happens when a woman gets an epidural during labor is that she can no longer move her legs. She should be numb from like the waist down, right? Like that's the point. So you don't feel anything. So she kept saying, no, I can still move my legs. No, I can still feel that. And they kept telling her, oh, honey, you're just feeling pressure. And she was like, no, look, I can move my legs. This is not normal. And they were like, no, you're fine, you're fine. Well, when it got to a point where it was time for her C-section, they rolled her back to the OR, and she told me the nurse pinched her side. And she said, okay, I felt that. And the nurse goes, oh no, you felt pressure. And she goes, no, I felt you pinch me. And they said, no, it was just pressure you felt, you're fine. And they started doing the surgery. And she felt it. She felt all of it. She said she was screaming and asking them to stop, and they had denied her husband entrance to the OR with her. She said they told her they didn't believe that they were married, and therefore he wasn't allowed in there. Now, this was last year, like 2019, so it was pre-COVID. So it wasn't like there was any excuse whether or not they were married. He was her support person and should have been allowed. But she was screaming in pain because she was feeling them cut her, and they kept telling her that she was making it up. She said she heard her baby cry, and then she passed out. Now, she believed she was going to die in that OR, and she really did. And I don't blame her. I mean, I think she said her last thought before she passed out was, this is how I died. They're trying to kill me. And which is heartbreaking, right? But it shows how the belief that Black bodies don't feel pain like white bodies is still rampant in medicine today. Because had that been a white woman on the table saying, excuse me, I still feel you, they would have made sure that she had adequate pain management before cutting into her for a major surgery. So one of the other myths, there are lots of things about medical distinctiveness that I could talk about, but one of I'm going to move on to the next myth, which is selection of Black people and people of color and minorities and even poor people for the riskiest of studies. And one of the biggest things that brings to mind are radiation studies in the 1940s and 50s. So after World War II, the American government, being the stellar people that they are, brought 700 Nazi scientists over from Germany, pardoned them, changed their names, and stuck them in hospitals all over the country, and allowed them to continue the research that they had been conducting on Jews in Nazi Germany. And because it was the 1940s and 50s and no one had any rights, they didn't have to have informed consent. And so they continued their radiation studies on people of color that would come into the hospitals in all over the country. This happened in several different teaching hospitals all over the country. But they would inject patients with different kinds of radiation, radioactive isotopes and that sort of thing, like all different kinds of radiation, just to see what happened. It was very rarely done in a hopes of being therapeutic, and was most often done just to see what happens to a body. A lot of people died. A lot of people were permanently damaged from it. They did this on not only on adults, but on children as well. And never with informed consent. Most people didn't even know they were being injected. Some people who did know they were being injected were told that it was being done to try to save them from whatever the disease was that they had, but very rarely was that the case. So today, there are laws in place that don't allow for this as much. Although one of the things that is still allowed is if a patient comes in to the emergency room and is unable to give consent, that you're allowed to do whatever. A lot of states actually allow you to do whatever with patients if they can't give informed consent. So you can enroll them in a research study. You can give them experimental treatments instead of treatments that we know are best practice at the moment. Like if you're working on, one of the things that happens sometimes is that patients get like artificial blood instead of real blood. If they can't consent to the treatment, they will try out different forms of artificial blood that we are working on so that we don't need to use human blood anymore. But again, it's done only to people who have minimal recourse, right? So most of the time, those are going to be your poor people, your people of color, your immigrants, and people who have very little option of legal recourse. And most of these people are also underinsured. And so they are being treated charity, I guess, with no expectation of them ever being able to pay, and therefore the hospital and the doctors feel like they can use these people for research. So the next important pattern is disproportionate selection for non-therapeutic experimentation, which is similar to the radiation studies, which were non-therapeutic. But the biggest non-therapeutic experiment that is known throughout America, and that actually very much changed the scope of how people of color are treated in medicine, was the Tuskegee Experiments. Now, most people know about what happened at Tuskegee, but just to give you a little background, 1932, it was a syphilis study. They recruited men they recruited men specifically because they were looking for sores, and it's easier to see sores on a penis than it is on labia. So they recruited men who were infected with syphilis and had already been through phase 1, because by then they knew that syphilis was like, you got phase 1, which was like sores on the outside of your body and like flu-like symptoms, and then it could go dormant for a really long time before, and that's phase 2 is when it's dormant, and then phase 3 of syphilis is when you start getting things like the brain damage and neuropathy and all kinds of other crazy things. In 1932, when the study started, we didn't have a good treatment for it. They were using things like mercury, and I mean, there were all kinds of crazy things they were trying to treat. They didn't know syphilis was a bacteria that could just be treated. We didn't have penicillin. But the study continued. So here's what they did. They recruited all of these men to the study. They told them they were going to be receiving treatment, and then they did nothing. They literally had all of these men in this study, and you know what? I didn't even write down how many there were. There were a lot of them. All of these men in this study that they told they were giving treatment to, gave them no treatment, and then they just watched them just to see what happened. It was in no means a therapeutic experiment. They were just watching to see what happened. So that study continued up until 1972. So 32 to 72, 40 years, they studied these men. They watched them die. They watched them give syphilis to their wives and their children. They watched it happen and did nothing. They just followed them. We found penicillin in that time, right? And even when penicillin became available and we knew that penicillin cured syphilis, they didn't do anything. They didn't give them penicillin. They didn't treat them. There's some talk of them actually having used these men and their like blood full of syphilis as research. Like they just kept taking blood from them to continue to have syphilis on hand so that they could do research on how to cure syphilis, but they never actually treated these men. They never treated these men. In 1972, the story broke in a newspaper. A journalist broke the story, and that's what stopped the the experiment because people got mad about it. People found out about it and then got mad about it. And President Clinton actually apologized to the experiment victims in 1997, I think. He did is that right? Sometime in the 90s. He apologized because it was one of the largest and just cruelest studies ever done, because they could have treated these men 100 times over and they never did. So that non-therapeutic experimentation, just to see what happens. One of the other myths is, so one of the other things that happens a lot is the use of Black bodies at cheap, no cost, little cost, to then generate profitable medical things. So like Dr. Sims and his fistula surgery, he made a lot of money off of once he perfected his fistula surgery, he made a lot of money off of it. And nowadays, one of the ways that shows is vaccine experimentation. We don't do a whole lot of it in America anymore, but we've just taken our experimentation on Black bodies and now we do it in Africa, where doctors use the excuse of being unable to explain what it is they're trying to do to parents, and then they experiment with their vaccines on African children. There was a measles vaccine that they used for a very short period of time in, I want to say, the 90s, and it killed like 200 kids or something. Like, it killed like an exorbitant amount of children before they were like, maybe we shouldn't use this vaccine anymore. Now, that wasn't done on American children, but it's the idea that they were looking for ways to make money and profit off of this, and using the expendable people of Africa in order to do it. So that's a little bit of the history. I want to go back to the myth of medical distinctiveness, because one of the things that I think, not only is it medical distinctiveness, but with slavery's first inception, okay, humans had to have known that keeping other humans as property was a bad idea, but they had to rationalize it to themselves somehow. So one of the things that they did was they convinced themselves that African people, when they were brought to America, they were unable to care for themselves. They were stupid, unintelligent, they couldn't learn. And because they were stupid and couldn't learn, they couldn't take care of themselves. They couldn't financially support themselves, and they needed someone to care for them, because that's what slave traders did. They cared for these people. But, so that's how they rationalized it to themselves. But those beliefs, the two main things I see in my work more than anything, is the belief that Black bodies don't feel pain like white bodies, and the belief that Black people are stupid, and so you don't need to explain things to them. Because I have another patient who had a miscarriage before her successful pregnancy. And when she came to me during her pregnancy, I asked about previous pregnancies, and she said, well, I had a miscarriage. She tells me this story. Now, I have had a miscarriage, and I can tell you, when I lost my baby, the doctors were all so very kind and considerate and explained everything to me, told me, like, they were so sorry that I had lost my baby. They told me how far along I was when I lost my baby. They told me what to expect when it became time to pass the fetus. Like, I got so much detail and so much kindness from these doctors, and I felt so well cared for. Now, I always contrast that with the story that my patient told me. She went to the hospital, she'd started bleeding. She wanted somebody to check on it because she knew that wasn't normal. She went to the hospital, they did an ultrasound, and they told her that her pregnancy was no longer viable. And then they left the room. Now, my patient is an educated woman, right? I think she has an associate's degree. She doesn't have a bachelor's degree. She's not a doctor. She didn't know what the word viable meant, like a lot of lay people in America wouldn't know what the word viable meant. They said, your pregnancy is no longer viable, and they left the room. She didn't know what that meant and didn't understand that her baby had died. A nurse came into the room and was like, it's okay, honey, you'll be able to have another one. And that was the first inkling she got that there was something really wrong with her baby. They sent her home, having just told her that her baby had died, and didn't tell her anything else about what to expect over the next few days. They didn't tell her that she would have to pass the baby. They didn't tell her what to expect when it came to how much bleeding was normal and when she should call the doctor and what she should do. They gave her no information. So a few days later, when she started bleeding, she thought she was dying. She called an ambulance, and they took her to the hospital, where the hospital looked at her like she was crazy and were like, no, you're just having your miscarriage. We told you this was going to happen. Now, I see this a lot with my patients, that the care that I receive from doctors is very different than the care that they receive from doctors. And the only difference between us is the color of our skin. Like, I'm a woman in my 30s, and I go in and I don't ever tell doctors that I'm a chiropractor, because I don't want them to, I want to see how they'll treat me. Maybe maybe I like to test them a little, but it's amazing to me, the difference in the time and the care and the explanation that I get from doctors, and the time and care and explanation that my Black patients don't get from their doctors. I spend a lot of my time with my patients. Now, not so much because True is their midwife and she explains everything, but if they're not receiving their prenatal care with us at Jamaa and they're just coming to me as the chiropractor, I spend a lot of my time with them explaining to them what it is that their doctors have told them and telling them that they have choices. It is still continues to be a prevailing thought in medicine today that you don't need to explain things to Black people because it's not worth it, because they can't understand you. And doctors will probably fight me on that, because I know that's not an explicit thought. That's not a conscious thought that they have. But I see it time and time again that it is an unconscious, let's call it implicit belief that they have. I get things explained to me. My husband gets things explained to him. My Black patients don't. I've had partners, men in my office, talking to me about things that the doctors have told them are wrong with their bodies, that I'm like, do you know what that means? And they're like, no, I mean, I kind of Googled it, but, and it's appalling to me how little explanation my patients get for what they're going through. So, you can see, I have so many more examples, you guys, but I'm gonna pause here. I wanted to give you some things that you can do to help in decreasing the instances of racism in medicine. It's a really big, heavy topic, and it feels really big and heavy, and I have only scratched the surface, and I'm not even sure I did it well, but there are some things. So Black people are just more likely to die from almost every illness if they enter the hospital than white people are. Black mothers in St. Louis are 2.5 times more likely to die due to childbirth or pregnancy-related complications than white people are. Black infants are almost 3 times as likely to die as white infants during the neonatal period. And there is no difference between Black bodies and white bodies. So there's no reason why, there's no good medical reason why Black women and Black babies should be dying at the rates that they are. And it has to do with racism in medicine. It has to do with not explaining to patients what's going on so you can't get informed consent. It has to do with not believing them when they tell you that there's something wrong with their bodies, because there's that implicit belief that they're drug seekers, that that they tolerate pain better, so they don't need pain medicine. There's the belief that they are that they're non-compliant and that they lie to you. I mean, there are all kinds of beliefs in medicine that make it so that these women and children are dying. So here's what we can do about it. One of the biggest things we can do is universal health care, because here's the thing. White people tend to have jobs that come with benefits that give them insurance. They see their doctors for every little thing. My knee hurts, I think I'll go to the doctor. Gosh, I'm having a little bit of heartburn, I think I'll go to the doctor. I've been having headaches every day for a week, maybe I'll call my doctor. That's what white people do. Now, Black people tend to work lower paying jobs that don't come with benefits. And so they tend not to have insurance. So here's what happens for them. My knee hurts, nah, I gotta go to work. So I'll just bear with it. or I'm having a little bit of heartburn, but you know, it's probably nothing. And then that little bit of heartburn is actually a heart attack. And so then they end up at the hospital in the middle of a heart attack, which costs a lot more money than had they just gone to the doctor and found out that they were having heart problems to begin with. Now that's a big example, but if all people had access to healthcare, we would, number one, we'd save ourselves a ton of money because we wouldn't have people showing up at the last minute needing really expensive procedures. We'd have people showing up when they first got uncomfortable. So voting for healthcare, fighting for universal healthcare is super, super, super important. But in the state of Missouri, one of the things we can do is we expanded Medicaid, which is great. But one of the things that I have learned is that Medicaid doesn't cover a lot of, so most of my clients at Jamaa have Medicaid insurance, right? But Medicaid doesn't cover home births. Medicaid doesn't cover less intervention, birthing centers, and that sort of thing. Medicaid covers like the bare minimum medical interventions for everyone. But Black women aren't safe in hospitals. Black women aren't safe with white OBGYNs, and they want other options. And so one of the things that we're working really hard is to try to get Medicaid to cover CPMs, certified professional midwives, instead of certified nurse midwives, so that, because certified professional midwives are the ones that do home births, where certified nurse midwives work in birthing centers and hospitals. So to get CPMs covered by Medicaid so that these women have options of births outside of hospitals where they die. One of the other things is always making education more accessible, not just like everyday education, but like medical education, so that more people of color can become doctors and nurses. The more people of color there are caring for people of color in hospitals, the less likely people of color are to die. You've probably seen the article that came out recently about Black babies are less likely to die when their caregivers are Black. When they have Black nurses and Black doctors, they're less likely to die. Black women are less likely to die when their caregivers are Black. So encouraging more people of color to enter the medical field is one thing we can do to sort of combat that inherent racism in the system, which means making the education more accessible. The other thing that we can do is to notice our own biases and recognize them and try to change them, but also to call them out in people when we see them. Offer your services to your friends of color when they're going to the doctor if they need someone to go with them. It feels very personal and intimate, but sometimes having a white face in the room makes all of the difference. And that's sad, but it's a sad reality that we sort of have to deal with. And so, you know, if you have that kind of relationship with a person of color and you can be of service to them, I encourage you to just say, hey, I'm here for you. I'm happy to go and sit silently in the room just to be there. I personally feel that it's important for white people to use their privilege because we have it. Until we no longer have it, we need to use it to lift up people of color. That's a firm belief that I have. And so, okay, I think I might be done talking. I hope that that was helpful. I hope that it was educational. I am happy to answer any questions if I can. But please go out and be the change that we want to see in our world, as overused as that quote is. I appreciate you taking the time to listen to me talk tonight, and I'm here to answer questions for as long as you need me. Thank you. Oh, thanks, guys.
Yeah. Are we not now mute?
No, we're not mute.
People can unmute themselves now.
Yeah. Any questions? Just speak up if you want. You don't have to go through me or anybody else. Just say something.
Jim, yes. So I will say that the research shows that, so Jim's question in the chat was, do Black doctors do a better job with this? Jim, I'm assuming you mean with implicit bias?
With Black patients, yes.
Yeah, and they do. And so my friend, my friend who is a psychiatrist, she's in her residency at Yale, and she says often she will be the only Black doctor in a room of like 8 doctors when they go on rounds throughout a patient's room. And she says almost always her patients of color will like kind of wave at her and ask her to stay back when the rest of the doctors leave the room, and they'll check in with her. Doc, do you think that's the best? Is that the best, the best care plan? Do you agree with that? Do you think they're taking care of me? And she says one of the things that almost everybody says to her is, I'm just a little nervous. You know what I mean? Like so Black doctors notice the racism. And that's one of the things that my friend says, that she very much tries to call it out when she sees it. She does pick her battles because she has to stay a professional, but she does, try to call it out when she sees it to make the rest of the doctors around her better.
Well, my other question would be, do you see any effort in the medical schools to bring this, to make this more about, to educate doctors about the need to be more aware of this?
I do. And I do think it's changing. I think we're getting more doctors of color, which is really important. But the other thing is that implicit bias training is becoming more of a thing. Now, a lot of hospitals say that they've done it, and they'll do it for staff too. They'll do it in medical schools. They'll do it in the hospitals for the nurses and everything, and they'll say that they've done it. I haven't been super impressed with implicit bias training that I've heard of. It's basically like, don't use the N word and like try to be nice. And like, how helpful is that? I think we're so hesitant to want to call anyone racist who isn't like being, wearing a white hood and burning crosses. And so, because it's such a difficult word, right? Like nobody wants to be called a racist. But what we have to see is that we have to be able to call out these little like microaggressions, because those matter just as much. And what we see is Black people are dying more because they're afraid to go to the doctor, because they're afraid the doctor's going to kill them. And so what we need to do is get past that fear. And one of the ways of doing that is acknowledging the bias and then trying to work from that, right? And so, so I do think that medical schools are doing better at it. And I do think that hospitals are trying, but it's a huge problem that's been going on since the inception of America. And it's just going to take time, and it's going to take consistency.
Thank you.
Can you talk more about Jamaa, what it does, its history,
Carol, was that you?
Yes.
Okay. Yes. So Jamaa True Kelman is Missouri's first Black certified professional midwife, and she founded Jamaa 5 years ago. She has had 3 children, 2 really terrible experiences. She was 14 when she had her first child and 18 when she had her second one. And her third birth was a beautiful home birth, and she just fell in love with midwifery and decided to become a midwife. So she founded Jamaa, which is an equal access midwifery clinic, which means that we provide care to everyone who comes to us, no matter their ability to pay. And so True does home births. She attends home births. She has a second midwife, Jen Jester, a white midwife who practices solo on her own here in St. Louis, but she is also our second midwife at Jamaa. And they practice together and they attend home births. But True also provides prenatal care to a lot of women who then end up delivering with doctors or midwives in hospitals around the area or birthing centers. We just opened this beautiful new building like during COVID, so no one's gotten to use it, but eventually someday we're going to offer, so chiropractic care, we have a massage therapist, or we will have a massage therapist eventually. We have mental health counselors, because one of the things that we see is that it's very difficult for Black women to admit that they're struggling with mental health. And so if we can have someone on site to recommend to them, like, hey, why don't you go talk to her about how you're dealing with postpartum or whatever, that's more likely to happen. So we have a mental health counselor, we have breastfeeding, lactation consultants, that's the word I was looking for. A lot of staff doulas. We provide doulas at little to no cost to anyone who wants one. And so it's a one-stop shop. Eventually we'd like to make it into a small birthing center. So if women don't want, Yeah, so if women don't want to have a home birth, but also don't want to go to one of the hospitals in the area, that the eventual goal is to have 1 or 2 birthing suites, but the permits for that were different than for the clinic, so we started with just the clinic. But the eventual goal is for it to be a birthing center.
Thank you.
You're welcome. I know a lot of people at the society donated when we were fundraising for the new building, and actually the Poe family sponsored my room, so their name is on my door, and I think of them every time I go to work at Jamaa. It's very nice. Yeah, but I think the Womptons adopted a room too, so I think maybe they're the lactation room. I've seen their name around.
Can I interrupt and tell a story? So Sharon Poe donated her Trump stimulus check to Jamaa. That's why the room is there.
Yes, I love that. Yeah, their name is on my room.
Great
I love
idea.
it.
Nikki, can you say a little bit about how chiropractory helps with birthing?
Sure. So, there's something I know about. Okay, so chiropractic care is about the balancing of the bones and the nerves, because we work with the spine. Most people know of us as spine doctors, but all the nerves that run in our body run out of our spine. So a lot of the work that I do also impacts the nervous system. So with pregnant women, what we're doing is trying to keep the pelvis balanced, and in keeping the pelvis balanced, it allows for the hole that the baby comes out of to be as big as possible, which means that it's easier for the baby to get out. So a lot of what I do is pain relief for women during pregnancy, because anyone who's been pregnant knows that being pregnant is the most uncomfortable you'll ever be in your life. And one of the things about pregnancy that's difficult is that there are a lot of you can't take most pain medications. You can't take most medications when you're pregnant. And so a lot of women are super uncomfortable and don't have very many relief options. So what I do is pain relief in helping keep their pelvis balanced and helping keep their muscles relaxed and helping give the baby as much room in the uterus as we can. We remove restrictions in the round ligaments and that sort of thing. And so it gives the baby room, which gives mom room, and which keeps everybody comfortable. But studies have shown that regular chiropractic care during pregnancy and keeping the pelvis balanced also decreases labor times, makes them less painful. You're less likely to get things like back labor, which can be super painful and make things last a long time. So yeah, most of my patients have relatively short labors, not all of them, birth is questionable, but yeah, so it keeps them comfortable and makes labor a little bit faster and easier usually. And then, postpartum, it just helps heal a little bit faster.
Thank you.
You're welcome.
Nikki, are you ever in touch with places that deal with predominantly white women, but of low socioeconomic status, to see how they are treated, if there are some comparisons to be made?
No, I don't have a whole lot of experience. Now, I have had a few low-income white women come to me at Jamaa. We don't discriminate. So we cater to Black women. So most of my patients there have been Black, but not all. And I have had a few low-income, but again, so it's interesting because low-income white women still tend to have better insurance than low-income Black women, which, at least in my experience, that's been my experience with my patients. They still have better access to healthcare than, and I also find that the lower income white women I work with still seem to know a little bit more about what to expect during pregnancy than the Black women that I work with. So I don't know what that is. I don't know if they've got doctors that explain it better to them. Yeah, I don't know, but I do know that a lot of my Black moms will talk even about taking their kids to the pediatrician and how they're if they're on state insurance, they get different care than when they're not. I've had moms that have been on Medicaid and then gotten jobs with gotten a job with benefits, and then they're on different insurance, and the whole attitude of the pediatrician's office, same office, totally changes. And it has to do with income level. So I would assume that that's the same for white women as well. And that's just a discrimination in insurances. I don't work with insurance on purpose because I don't want to treat my patients differently because of it. So.
Yeah. Okay, thanks.
You're welcome.
I was also thinking about elderly people with my parents and my husband's parents when they were alive, and the kind of treatment that they get. And part of it is the less valuing of them as human beings because they're gonna die anyway. Sometimes being working class, there's a bias, or maybe they don't have a college education and there's a bias against that. But that whole thing of valuing them as human beings.
Yeah, one of the things that has made me super nervous throughout this whole COVID pandemic is all of the people going into a hospital alone. Because one of the things that we talk about, one of the things that I talk about a lot is always taking someone with you when you go to the doctor and always having someone else there. And we teach our patients to do that for just practical reasons. If you're getting a diagnosis and the doctor's giving you a lot of information and you've just been told that you have cancer or something, your ability to take in the information that the doctor's giving you is much reduced simply because you're in shock. And so it's always good to have a second person there who is hearing it as well so that you guys can discuss it later. But also, just because sometimes doctors will say things to a single patient alone that they would never say in front of family. Yeah. And I agree with you that it is, as patients get older and we just assume that they're going to die soon, there does seem to be this this feeling of cavalier treatment, or that doctors are more willing to experiment with older patients. And especially if you're older and a person of color, there's a reason older Black people will do anything but go to a hospital because for years and years and years, all of American history, if you were in any way incapacitated and you were a person of color and you went to a hospital, you weren't coming out alive. And sorry, my camera just freaked out. Okay, well, I'm just gonna have to hold it now. Sorry. So anyway, one of my concerns with the not allowing people, and I totally understand the need for it, but I do worry about the lack of advocacy for fragile and vulnerable patients in healthcare, because you're right. I do see that. I see that in vulnerable populations. And while no one's going to say, give me your kid, stay outside the hospital and not allow a parent into the hospital with their child. My grandfather, who has Alzheimer's, had to go to the hospital during the COVID pandemic and they wouldn't let my grandma go in with him. And I was like, okay, but he literally has the capacity to think like a 5-year-old, and you wouldn't take a 5-year-old from the parents and be like, come back in an hour. That's just not something one would do. But they did that to my grandfather because he's old. He's an adult, and he is an adult, but he doesn't have the capacity to make medical decisions for himself. Yeah. And that was a really scary thing for him and for my grandmother. So I don't know.
So there's an interesting contrast between Black people, as you're saying, being reluctant to go to a hospital, and the use of the hospital emergency room instead of going to a physician, which they're afraid to. I guess it's like waiting until you absolutely is life and death.
Yeah, that's exactly what it is. They avoid healthcare as long as they possibly can, but then by the time they go, they need so much more care than they would have needed had they just gone to a doctor months ago when the problem started. And that's I mean, there's this whole book, she just gives case after case after case, like decade after decade. There's always something happening that that just solidifies even further reasons why Black people shouldn't trust doctors. Dear goodness, I read this book and I thought, well, I'm never going to a doctor again, and I'm white. Like, it was terrifying. Like, just some of the things, like, and it made me like, oh my gosh, like, are doctors are known for having a bit of hubris, right? But some of these doctors, I just thought, like, your first thing is do no harm, but it doesn't say first do no harm to white people. It says first do no harm. Like, it's amazing to me. It's amazing to me what American doctors have been able to get away with.
Do you have any sense that female physicians are less guilty of some of the things you're talking about?
It's a good question. Yeah, sometimes. So physicians were really only men for most of history, right? So there were no stories of female physicians in this book that I can recall. Granted, I haven't totally finished it, but of all the history, like, they were all male names. Now, there were some nurses, like there was a Black woman who was a nurse in the Tuskegee experiment, who her job was just to follow these men and make sure they didn't get lost or the experiment was a bust, right? But like, how complicit was she? Like, they just told her to do this and she did. Like, she didn't really understand what was happening. But there weren't a lot of female doctors. And so I would say for some things in some branches of medicine, female doctors are less likely to, it's hard to, I don't know. And I don't know the statistics on that. Like, OBGYNs still, I think, have it, like, just from what I've seen in the work that I've done, I feel like OBGYNs are still pretty, male or female, they're still pretty questionable. But OBGYN is one of the few branches of medicine that doesn't follow best practice very often. They're very behind the times, and so that's hard. It's hard to know if it's just OBGYN, they do what's convenient for them and not what research says is best, evidence-based practice.
So can you give an example of what you mean?
Yeah. So induction rates in or C-section rates for that matter. So C-section rates are about 30% in America. The World Health Organization says they should be somewhere around 15%. So we're about twice what they should be. And that goes a long way towards induction rates, because we also have higher induction rates than are necessary. We know that we know that labor times get longer when you don't allow a mom to move during labor, but a lot of hospitals will require a mom to stay in her bed if she's hooked up to even just an IV. We know that C-section rates increase when you induce a mom, but doctors, good grief, will look for any excuse to induce a mom, especially if they think she might have a baby on a day that's inconvenient for them. And so that's, I mean, there are a lot of things that happen in hospitals that have been shown are not necessarily, well, like, okay, so babies usually get the cream on their eyes when they're born. I don't even know what, it's like silver nitrate on their eyes or something. And it's like 100% not necessary, because it's there as like a gonorrhea treatment, but like, we test for STDs in the first trimester. And so if mom's got gonorrhea, we know that, but if she doesn't, we also know that. And And yet all babies in hospitals get that eye cream. And while it might not be harmful, it's not necessary. And we know that, and yet it continues to be a thing that happens for no reason. So yeah, OBGYN doesn't, it's very different than almost every other branch of medicine, that it just doesn't stay up with research and implement the research as it comes.
Wow.
Okay, I was curious about how you establish trust. And this comes out of this context. Probably 25 years ago at the university that I taught at, I tried to place students on the Indian reservation that was basically in our town. And for 10 years I failed. And then finally another student got placed, and then another. And finally people began to get placed, and I developed a relationship. And so when you talked about forming a trusting relationship, that was the basis for my not being engaged. And slowly, I mean, it took an awful lot of years. So I was curious if you could talk about that.
Yeah, so one of the biggest things that has helped me is that the women that come to Jamaa trust True, and True shows them that she trusts me. And so that has made a big difference. And but then I think it just takes time, and I'm very consistent with them. I'm very careful to never show any sort of judgment. I try to just live my life that way, right? Like, your choices are your choices, and if they don't affect me, then I'm not going to judge you for them. And so, but that makes a big difference to them, because I feel like a lot of my patients feel like their doctors are always judging them, right? Like when a patient says to me, I'm pregnant, I don't actually know who the father of this baby is. And I'm like, okay, so what are your plans for support during labor? And we move on, right? Like, she's not going to get any judgment from me for that, because I don't know her life, and that's none of my business, right? But it's a means of consistency, of always being there for them, of never showing judgment. But one of the other things that I've tried really hard to do is, in all of my marketing, I try to use women of color, like pictures of women of color, when I'm marketing my practice, so that they can at least see that I'm aware of, because most of the time in marketing, white doctors market white people, market to white people. And I try to be very cognizant of that, so that they can know from the minute that they walk into my office, whether it's at Jamaa or at my office, that that I'm a safe space for them. So one of the other things that I did before COVID, we have moms support groups at Jamaa, and I made a point of going to group every week. It actually was a lifesaver for me, honestly. I didn't even realize how much I needed it until I started going. But the other thing was that I got to know a lot of women that way. And they got to know me, and I could be vulnerable with them, and then they could know that I was struggling with some of the same things that they're struggling with. Not all. I learned a lot about what life looks like when you're not privileged. But I built a trust with them that way too. And so all it took was one or two people trusting me, and now they tell their friends, you can call Dr. Nikki, she's wonderful, she'll help you, you can trust her. And that means the world to me, and I work really hard on never breaking that trust.
Thanks.
I don't know if that was helpful.
We're getting close to the 8:15 mark, which is a time that we generally call for whether there are any more questions. Nikki, can you stay on for a few more minutes if people still want to talk with you?
Yeah, sure.
Do we have any more questions? Well, I'll ask one then.
Okay.
Do you have you had experiences with any indigenous folks about whom you could relate a little bit about how they feel they get treated?
So we did have an intern at Jamaa last year who is, she grew up on a reservation in Michigan. Now, I'm not going to remember the name of her tribe, although she did tell me.
Chippewa? Was it Chippewa?
I don't think so. It was not. It wasn't one that I recognized, and Chippewa's one that I know. But are they always called Chippewa? It wasn't Chippewa something that white people gave them, but they called themselves something else? Or am I making that up? I don't know. Anyway.
The reservation adjacent to our community was Chippewa.
Yeah, I don't even remember where, I just know she was in Michigan, but she was an intern that we had at Jamaa for a bit last year. And I had never, there was a girl I went to school with when I was a kid who was Native American. She was adopted by a white family, but she still like did some stuff with her tribe. And like, that was the only experience I had ever had with anyone who was Native. And so our intern, her name was Sierra, and she taught me a lot about what her experience had been like. Now, she was white passing. One of her parents is white. The other one was Native. And she very much looked white. And so she talked a lot about that experience of growing up on the reservation and looking like she didn't belong there, which was really interesting. But she did, her experience is a lot the same as the Black people that I meet. Although I will say, I think she was kind of insulated on her reservation, and life on the reservation was very safe for her. But then when you travel outside of the reservation was when things would be less safe. But they also I don't think they receive as much care as they need. We sort of put them on reservations and forgot about them. And so that's been her experience, was that she was working with us at Jamaa to get experience as a doula so she could go back. And I think eventually she wants to become a midwife and be delivering babies on the reservation so people didn't have to leave the reservation to have their babies.
Thank you.
All right, Nikki, this is Ann. I have a quick question. You keep referring to the name of the organization, Jamaa.
Mm-hmm.
And how do you spell that, and where is it located?
It's Jamaa. It means family in Swahili, and it is located at. We moved, and I haven't learned the. Yes, thank you, Ethical Society. I guess that's James. The website is jamaabirthvillage.org. I think it's 40 North Florissant Road. It's right across the street from the Ferguson Public Library on Florissant Road.
Okay.
Check out their website.
Yeah, and it's an old medical building that True had completely renovated, and we grand opening during on Juneteenth was when we did our grand opening, but then we haven't actually been allowed to have people in the building, so it's there, and we have minimal patients. We do as much virtual as we can, although I can't do virtual work, so patients come to see me, but True does most of her work virtually, so we don't have to bring patients in as often as possible.
Right. And a few years ago, there was a story about a woman, and maybe this is the same person, who wanted to partner with, I think, Mercy Hospital or St. Mary's. And
it was Mercy.
There was a big controversy about that. So then I think she just finally decided to set up her own practice. Is that what was the story?
No, so True had opened Jamaa, but she'd been working with Mercy Birthing Center, and they were sort of partnering because it was before True had finished her midwifery work, so she wasn't attending births in Missouri, and so she was doing the prenatal care, and then the women were going to the Mercy Birthing Center to have their babies. But Mercy then announced that they were opening a satellite clinic, not a birthing center, just basically exactly what Jamaa does, just down the street from Jamaa, and they took everything that True had shared with them over the years that she had partnered with them, and they were going to use it for themselves. And it was a very bad faith thing that they did. And True was rightfully angry and hurt by it. And there was a bit of a public outcry, and Mercy decided not to open their birthing center in Ferguson. And so the partnership between them ended. So we don't work with the Mercy Birthing, or Jamaa does not work with the Mercy Birthing Center any longer.
Okay, thank you.